Okay, folks, I'm sorry about the little technical thing there, but thank God the mouse started working and now I can do my stuff. So, thank you all for your time today and coming to listen to us. We've got Dr. Brandon Lundell here to do a great webinar on how he uses his huge super panel in practice and how he gets the great information that he needs to treat his patients. So Dr. Lundell has been practicing and teaching integrative health and medicine for over 15 years. His approach to patient care empowers patients to take their health back by understanding the cellular, dietary, and lifestyle origins of disease. He uses laboratory, physical, and history findings to uncover the source of ill health and organ system dysfunction. He's developed a certification course for licensed healthcare practitioners called Nutrition Pathology. We'll see that on one of the slides here. And he also has a terrific book on laboratory interpretation, the Holistic Blood Chemistry and Urinalysis Manual. That's a great thing to have handy in your office. Dr. Lundell's done extensive lecturing for various professional organizations and companies such as Professional Co-op and others. And he's been a good friend to us here for many years. We appreciate his terrific knowledge and his willingness to share it. He served as an adjunct professor at Southern California University of Health Sciences, where he developed and taught a functional medicine program for graduate doctorate students. And thanks so much for being here, Dr. Lundell. We truly appreciate it. And we will just let you take over for now. And
Yeah,
some of the slides
great.
will show the next webinars we're offering. And also, there's a disclaimer there that we'd like you to have a look at as well. It just basically says that this is not to be construed as medical advice, and it's your decision to use or not use any of the information you might hear today. And Dr. Lundell has a couple of things that he'd like to discuss as well. So I'm going to just go ahead and say thanks for being here, Dr. Lundell, and go ahead and give us some really good information, which I know you're going to do again.
All right. Yes. Thanks, Bill. And yeah, thanks Professional Co-op for putting all of this together. And please do check out everyone that's listening. Professional Co-op has been putting together quite a library of educational videos. I've done a few of them in the past, B12 deficiency and things like that. So please check out their archived webinars and also some upcoming webinars here. The next one is next month, diagnostic testing and functional medicine approach to common lung disorders. Dr. Kleber, who I know is a good friend, he always has great information. So,
yeah, and you mentioned your B12 webinar that you have done in the past, and there's also some basic blood chemistry things we've done with you, and autoimmune and the mitochondrial function in those patients for previous webinars.
Yep, exactly. So please take advantage. So, all right, let's get started with today's topic. Just conflicts of interest. I am a pay presenter for Professional Co-op, but I do not receive any financial compensation of any kind for any of the tests ordered through Professional Co-op. So even though my name is behind it, I don't receive any financial compensation. So I put together this panel because it's something that I use in my practice every day with just about every patient. So I'm excited to share one of the most crucial pieces of laboratory medicine in my practice. So we'll talk about autoimmune and inflammation. How can you know if it is or will be active? The most important aspect you may not know about the CBC. We'll talk about infections, what homocysteine is really saying about methylation. We'll talk about urinalysis, all of the great information you can glean from the LabCorp urinalysis. It's one of the most sensitive tests for ketosis. We'll talk about mitochondrial function assessments that you can see just in a CBC and CMP if you know what to look for. We'll talk about hemoglobin A1C, hydration, CMP, and practical treatment options too. So we're going to do a case study to kind of put it all together. So yes, one of the things I love saying in my courses I have developed, as Dr. Bill Beakey has mentioned, a certification course for doctors in functional medicine and nutritional pathology. You can go to my website for that, Dr. Brandon Lundell. But good doctors know what to do. I can teach someone, we can learn what to do pretty quickly, but why? Why does this analyte show this thing? Well, what is this analyte showing? Why does this patient, express this illness? What is really, really happening in the body on a deeper level? To do that, we need a diagnosis, but not a Western medical diagnosis, but a diagnosis in the true form of what a diagnosis is. A diagnosis, dia, I love the study of words. Dia means throughout or thoroughly or from every angle. Gnosis means to know. So diagnosis means to know the true nature of something from every angle. And that's what functional medicine really is. And that's what blood testing really is. And so we do live in an era of misdiagnosis. It is something that, and Bill, can you make sure that they're seeing the slide progression?
Yeah, I just was going to interrupt here. Yeah, we are seeing the slide progression, but if you go to the top of your PowerPoint there, there's something called slide presentation.
Sure. Yeah, for some reason it's not loading.
Okay.
Yeah, so we'll have to make do. Yeah.
All right. No, fine.
If it does, then once it does, then I'll do it. Okay. We both are having technical difficulties this morning, but as long as everyone can see it, I know you can see the slide deck on the side too. But so we do live in an era of misdiagnosis. In this report, the Institute of Medicine's report on the devastating consequences of misdiagnosis, and Dr. Mark Graber leads the Institute of Medicine, and he's the founder and president of the Society to Improve Diagnosis in Medicine. And making a diagnosis is tough, especially in the Western model, because they're not looking at the true causes of things. So that's what we have to do. We have to look at the true cause of things. And medical misdiagnoses, or really an adiagnosis, right, which is the worst, which is not having a diagnosis. His report says very clearly that the most underutilized or mishandled aspect of reaching the correct diagnosis and therefore the correct treatment for a patient was laboratory medicine. The inability of practitioners, or the lack of knowledge by practitioners of every field to know what lab tests are really available to us. And that is true in functional medicine as well, although we have much more of a battery of tests available to us. So I believe that laboratory medicine is still the most misunderstood and underutilized clinical tool available to the modern physician. And so that's one of the things I really focus on in my courses is teaching laboratory medicine. What can we glean if you really know what to look for? And it starts with understanding what each analyte is in the body. What is BUN? Where does it come from? It's not a kidney marker test in and of itself. There's many other things that it can tell us, which I will get into here. So Professional Co-op was kind enough many years ago to allow me to do a panel back when they were doing panels. They don't allow individual panels, but I believe this is the largest panel that Professional Co-op and LabCorp has available at the time we filled their spreadsheet. But these are things that I want to test on every patient. This is the deluxe panel, what I call the deluxe panel, or the Lundell panel 1. Here's the code here, 376520003.
I'm going to interject a little bit of something here too. This is a panel that exceeds the result system in the LabCorp system. It has so many components in it that the number of results that would come back if all these results were filled is more than their system allows. So that's why you have to order the urinalysis separately. So you broke the system, Brandon. Congratulations.
Yeah, exactly. Yep. Well, that's what we're here to do, to change the system. So,
and we're going to make a little video to show folks how to store their favorite tests and how to create a requisition that's replicatable to make this very easy for people to order the tests they want all at once.
Yeah. So let's say that you I'll go through the components of what my panel is here in a second. But let's say you want to add your own that you just test for everyone. I often use Epstein-Barr or cytomegalovirus. There's a way that you can create a patient, like a dummy patient, and create that requisition that you want. And then whenever you are creating a new requisition, you can just copy and paste from that dummy patient into the new patient. So yeah, there's a lot of user-friendly things that save you and your staff a lot of time. So this first panel I use, it's pretty much a requisition or a requirement, prerequisite to see me. You know, I will do this panel on just about everybody because it gives me a good foundation to know what's happening biochemically in the body and then what other tests I might want to order. Now, the Lundell panel 2 is something that does not, I'm going to change this, does not contain ANA, or rheumatoid factor, thyroid antibodies, reverse T3, or vitamin D, because those aren't always something you want to follow up on. So this is more of a follow-up panel. Unless it's positive, you don't need to run, unless all of these are positive, you don't need to run the follow-up panel as the deluxe panel. You can choose this panel, which saves you a lot of money. It's $159 versus $275. And then if you want to do ANA, let's say the ANA was positive or the thyroid antibodies were positive, you can just add that on. So it saves you, saves your patients quite a bit of money. So here is what is in my panel. I hope you guys can see it. You can kind of zoom in if you need to. But so we start with a CMP, and this patient here, obviously diabetic patient that I just saw a couple weeks ago. Glucose at 133, hemoglobin A1C at 6.8. What I want to say, so everyone, I want all the listeners out there to grab their pens and you know, or you know, start writing down. I'm going to start giving you a lot of clinical pearls that only people who are listening will get. So hemoglobin A1C is misunderstood. It is definitely a marker of advanced glycosylated end products. It is an AGE in and of itself. So it tells you, you know, that someone is experiencing a high load and high blood sugar spiking. One thing that a lot of people don't realize, though, is that it depends on the average lifespan of the blood cell, which is 120 days. And if people are, you know, unhealthy, that actually their red blood cells turn over at a faster rate, right? They don't have enough glutathione, they don't have enough CoQ10, they don't have enough, you know, antioxidants. So their hemoglobin A1C is going to actually be a little bit, you know, artificially lower. It's going to show lower than it actually is. Why? Because the glycosylation that happens to hemoglobin A1C is time dependent. It's also the amount of blood sugar, but it's also time dependent. So if you're shortening the time of the life of the red blood cell, then you are going to have a falsely lower reading. Conversely, as patients start to get healthier, I see a lot of doctors making this mistake. The hemoglobin A1C might go from 5.3 to 5.5, you know, and you might think, oh my gosh, you what are you eating? You know, what are you doing? You're eating sugar in the morning or something, and really that's not happening. It's because if you're doing, you know, if you're practicing functional medicine, you're giving more antioxidants to your patients, more vitamin D, more vitamin C, more vitamin A, more vitamin E, curcumin, you know, green tea, whatever you're doing, and that is going to actually lengthen the lifespan of the red blood cell up to 6 months, some studies show. And so the hemoglobin, that's more time for those red blood cells to be glycosylated. And so just something to be aware of, that if someone is reporting a good diet, you know, don't think that there's some underlying pathological issue. And so you start giving them, you know, a bunch more glucose lowering herbs. You look at your other markers. You know, you can run an insulin level, you can run a fructosamine level, fructosamine is not dependent on red blood cell, length of lifespan. So just so you know, that's a good clinical pearl that a lot of people don't understand. Uric acid obviously is very important to run. Just a couple tidbits. Low uric acid is usually a molybdenum deficiency, and this is all in my lab manual. So if you go to my website, you can go to my lab manual, and I give sort of the differentials and why. Because xanthine oxidase is a molybdenum dependent enzyme, and that's the enzyme that makes uric acid. So if it's low, that's often in molybdenum deficiency. If it's too high, you can either be an over producer or an under secretor. An over producer is usually folate deficiencies and things like that. An under secretor is just someone who's dehydrated and someone who doesn't have healthy kidneys. So those are some of the differentials. The other thing that I have developed is a patterns manual. So let's say you have a list of differentials, right, from the uric acid, and you suspect that there's folate deficiency or something, or fatty liver. You go to my patterns manual, and what I've laid out is all of the analytes that you're going to see if that diagnosis is accurate. So you're going to see elevated liver enzymes, or you're going to see elevated triglycerides, those elevated ferritin or CRP. So that patterns guide is also very useful. The thing that I love teaching about blood chemistry is you never should make a diagnosis based on one single analyte. If there's a pathology going on or a dysfunction going on in the body, you're going to see it in multiple analytes. BUN, okay, BUN is actually a really good marker for two things. If it's low, then the patient's protein, so less, in my book, it's less than 11, literally in my book, it's less than 11. If it's less than 11, then studies have correlated that to low good bacteria, because there's a lot of bacteria in the gut, the good bacteria, the gram positives, that will break down the protein in your body and create urea, and that's blood urea nitrogen. So sometimes that's a good indicator and correlator to the microbiome. If it's too high, it's often dysbiosis or SIBO, a good correlative marker. About 70% in one study showed elevated BUN in people with SIBO. So again, it's not the only marker, it's not specific, but it is a good marker to give you a clue. This is why I run this test on every new patient, because it gives me a clue. If I start seeing these patterns, well, let's do a blood test, or let's do a hormone test. So speaking of hormones, the other clinical pearl I'll give you is sodium here. Low serum sodium does have a little bit to do with dietary intake, but only at the extremes. The body likes to control sodium very tightly, and it does so by which hormone, kind of think about it, give you a Jeopardy minute here. What hormone does influence sodium? It's aldosterone, and so it is actually a good surrogate marker for aldosterone, and studies have shown that. So in what cases would you have low aldosterone? Low aldosterone is often seen in adrenal fatigue, right? And or adrenal insufficiency. So low serum sodium can be a good surrogate marker for adrenal insufficiency or adrenal dysfunction. Elevated sodium can also be a surrogate marker for high cortisol, and high output of aldosterone as well. So again, aldosterone is the antidiuretic hormone. Aldosterone, if there's it keeps sodium. That's the main thing it does, is it acts on the renal tubulars to retain sodium. So, and it does that also with potassium as well. So if potassium is too high, that's often kidney insufficiency. But sodium is more accurate for adrenal correlations. So Carbon dioxide is also another really good marker for cellular respiration. It's a mitochondrial marker, and we have that just in the CMP. So if it's low, as it is in this patient, usually patients with insulin resistance do have low cellular respiration, low ATP production. And so that's going to show often in the carbon dioxide. It can also be a sign of kidney disease because the bicarbonate is secreted largely in the kidneys. But I see often the correlation between low carbon dioxide and low cellular respiration, some kind of mitochondrial dysfunction. If it's high, that's often a body that's very acidic, and so that's something that you can look at as well. Phosphorus is a good marker for kidney function. Usually high phosphorus is going to be a good indicator of kidney dysfunction. Sometimes people have high phosphorus if they are drinking a lot of sodas. In this case, she was. So something to be aware of there. Low phosphorus can be something called phosphate diabetes, something that it also shows some kidney dysfunction. So phosphorus is a good. Low phosphorus is also low when someone is not eating enough vegetables, right? Vegetables and greens are the body's major source of phosphorus intake. So just something to be aware of there. Magnesium red blood cell, most studies show that a red blood cell magnesium, healthy people, replete people, people who are highly functioning, their magnesium red blood cell is going to be above a 6. So even though the range here is 4.2 to 6.8, and you think, wow, 5.4 is right in the middle, she must be good. She's actually, a little bit deficient. And this is what I've done with my lab manual. A lot of functional medicine lab manuals, I don't think I need to tell everyone here how they come up with these reference ranges. For the most part, they take a large random sampling of what they think are healthy people, and they go 2 standard deviations from the mean. So there's a thought out there that if you just are closer to the center, then you're healthier. And while in some cases that might be true, that's not true in all the cases. Especially as populations get sicker and sicker, that curve undergoes what we call a left shift or a right shift. The whole population is shifting that curve over to unhealthy. So the middle of that curve no longer represents optimal health. So magnesium red blood cell is definitely one of those. Albumin is a really good marker. It's one of the best markers for hydration. And we can see, now we're starting to paint a picture. This patient, is dehydrated. Her albumin is 4.6, and the range is 3.7 to 4.7. She's got diabetes. She's got low mitochondrial function. And again, the sodium serum does not rule in or rule out definitively, an adrenal issue. She still may have an adrenal issue. But in my, years of practice, it's a very, very high correlator and surrogate marker. So what other marker are you going to see if they truly are dehydrated? Usually hemoglobin and hematocrit are going to be on the higher side as well. So something to keep in mind. Globulin, this is an important marker if you are going to run any kind of antibody test, because an antibody is a globulin. And some people have low globulins, especially if they have had chronic infections. So, if globulin is less than, 1.8 or 1.6 or even, 1.2, I've seen, some of your antibody testing, for instance, food sensitivity testing, may not be as accurate. So you may want to choose to support their immune system through healing the leaky gut, mushrooms to increase natural killer cells, balance out some of the inflammation. In her case, it's okay. It's a little bit on the low side, but it's acceptable for those tests. We have bilirubin as well, both total and direct. Let's see, her bilirubin so total is both direct and indirect. Direct is from the gallbladder. Indirect or total, if the total is high, but the direct is low or normal, then it's most likely hepatic in origin, meaning that the patient probably has some kind of liver inflammation significant enough, or hepatobiliary, scarring, or in Gilbert's disease, it's just a very, very tight, very narrow biliary tree, and so bile tends to back up into the blood. Those people do, in Gilbert syndrome, those people do have issues with detoxification. Those people tend to be more sensitive to chemicals, more sensitive to alcohol, more sensitive to the effects of more hormonal issues, because they're not getting rid of their hormones. They're not having the enterohepatic recirculation that normal people have. So those people you want to counsel on making sure that they're living a clean life, cleaning out their liver, things like N-acetylcysteine, burdock root, milk thistle, and also SAMe. And then in some cases, they may need some bile thinning salts, or some bile thinning, taurine, dandelion, that kind of stuff. Beets and beet greens are really good for that. Alkaline phosphatase is an excellent marker for zinc. Many studies have made that correlation between zinc levels and alkaline phosphatase. It is a zinc-dependent enzyme, and so if we see, now we're painting a picture. We've got magnesium deficiencies, we've got zinc deficiencies. This is likely someone who's got multiple mineral and electrolyte and trace mineral deficiencies. Usually they go together. If you're deficient in zinc, you're likely deficient in selenium, vanadium, chromium, and she's diabetic. And we know that about a third of patients who are diabetic suffer from severe micronutrient deficiencies, and that's why chromium and vanadium and trace minerals can really help those patients. About a third to maybe 40%. So now creatine kinase. Look at her creatine kinase. It's on the low side, and it's really low. This is another marker of cellular respiration, because creatine kinase is made in the muscle cells. It's made in all cells, really, but in a high amount of muscle cells, and it requires ATP production to make creatine kinase. So if creatine kinase is low, it's usually low muscle mass with a patient, which this patient had. She was overweight, so had low lean muscle mass and low mitochondrial function. So we are painting a picture here of everything that's happening. And we can see that with, LDH is also a little bit on the low side, but she's also inflamed. So that's going to raise the LDH. So it's just something to be aware of there. That's why you have to understand what each analyte is. Please do not rely on any one analyte to make a diagnosis and say, well, your creatine kinase is low, then you must have mitochondrial dysfunction, so we're going to go treat it. Or your LDH is fine, so your heart must be okay, or you're not inflamed. So there could be multiple factors on both ends that make it look normal, much like a macrocytic and a microcytic anemia. You could have a B12 and an iron deficiency, and your red blood cells look normal. AST and ALT, another really important tidbit, is these are B6 dependent enzymes. So looking at blood chemistry from a nutritional standpoint, from understanding what each analyte is, makes you so much better as a practitioner, and so much more helpful to the patient. So anything below, like in my lab book, I think it's an 11, 12. I love LabCorp's range. LabCorp's not looking at things from nutritional standpoint. So a 0 is normal to them, or they put a 0. They do that with homocysteine too, I think, in some ways, in some reports. But when it's 0, you're dead. I mean, you need AST and ALT. These are normal enzymes that are required for liver function. They are B6 dependent enzymes. Pyridoxal dependent enzyme, pyridoxal 5-phosphate. So it is a surrogate marker for B6 deficiencies. If it's, you know, on the low side, and for her, she's kind of borderline. But again, you can have a B6 deficiency and liver inflammation, liver damage, which is raising the AST and ALT, and everything looks fine. So, so look at those from you know, from a holistic standpoint. Now we get into some iron markers. We can see here that most of her iron is okay. She's not iron deficient by any means, but she's also not getting too much iron. Her serum iron is okay. Her iron saturation is okay. So why would ferritin be elevated? Well, it's quite elevated, and we can see that that is you know, an acute phase reactant, and so that is, you know, why it is elevated. So so ferritin being elevated this much is a sign of systemic inflammation, severe inflammation, something that's been going on probably long-standing. Usually, if it's up into, you know, 700-800, that's usually what we think of hemochromatosis. That's when you can run the HFE gene test if you suspect that. But in this case, it's really clear that how much inflammation is going on, how much it's damaged the liver. So at this point, you want to think, all right, she needs some liver support. And of course, the trace minerals will help with that, the B6. But in this case, I will use a lot of phosphatidylcholine to help the liver. You know, I might use some EDTA, some chelators to help the iron to get out. I'll definitely use some milk thistle, some burdock, some fiber in the diet to pull the iron out of the bile, so, and excrete it. So, but really, you have to deal with the underlying inflammation. Why get rid of the ferritin if you know, you're not dealing with the inflammation? So really, you know, then it's high doses of curcumin, grapeseed extract is one of my favorite. For her, alpha lipoic acid, we've already seen that she's got you know, diabetes. So alpha lipoic acid is going to be extremely important. Not only does that help with diabetes, it's an antioxidant. It helps with liver disease. It helps with fatty liver significantly. It helps with mitochondrial function. So she's a good case. For her, I would probably do 1,200 milligrams twice a day, or at least, you know, 1,000 milligrams twice a day. You can also dose it at 600 3 or 4 times a day. But having a consistent level of alpha lipoic acid is key. This is another quick clinical pearl about taking supplements and educating your patients. Most of my supplements I'm dosing for my patients twice a day. And the reason why is because we want that area under the curve, right? Area under the curve equals therapeutic benefit. If you're just taking a bunch in the morning, you get a spike and then it drops down. And so for the rest of the 18 hours of the day, you're not getting any kind of therapeutic levels. And so your treatment is not going, even though you're doing the right things, it's not, you know, it's not as effective as it could be. So area under the curve is important. So at least twice a day, dosing these things has been shown to be far, far more important. Now, vitamin D, what I'm going to say about vitamin D is that one of my favorite nutrition books is Dr. Alan Gavy's Medical Nutrition. I think I have it right over here. Yeah, it's one of my favorite books. And it's very clear because he takes a lot of epidemiological data. Vitamin D levels, the healthiest vitamin D levels are really right here at 45, long term. I know there's a lot of people out there that you know, promote high doses of vitamin D, and I think that there is a time and a place for that. If you are in an inflammatory acute crisis, if you are in an autoimmune crisis, infections, you know, and if you've been low for a long time, then high doses of vitamin D can be very, very helpful. But long term, there's a reverse J curve in all-cause mortality, right? So we have low vitamin D on the axis here, and all-cause mortality here. So we have it's all-cause mortality on this axis, vitamin D levels on this axis. So it's a reverse J curve. So yeah, low vitamin D, very high all-cause mortality. But long-term, the nadir of vitamin D, you know, and its correlation with all-cause mortality is right around, you know, 40, 45. So, so just keep in mind, long-term studies are very clear that if you start going above that, all-cause mortality starts to increase. So, so again, there is a time and a place for high-dose vitamin D, but long-term, this is where you want your patient to be at. And I think this patient, it's about one of the only things she was taking. So she was, you know, had good levels of vitamin D at least. And obviously, you know, she's got high triglycerides, high cholesterol. Where does cholesterol come from? The backbone of cholesterol is sugar, right? Sugar gets turned into a triglyceride. That's what glycer means, a triglyceride. And so that triglyceride then goes into VLDL and into cholesterol. So the you know, her diabetes is the source of her high cholesterol, but she's also developing fatty liver. Anybody with this high level of triglycerides usually has some fatty deposits in the liver. Elevated liver enzyme is the last symptom, last clinical marker to show up in fatty liver, okay? You see that she has CRP, very elevated. CRP is much more early in fatty liver. Triglycerides is much more of an early marker, as well as hemoglobin A1C and total cholesterol. So don't rely on liver enzymes to say she does or does not have, or a patient does or does not have fatty liver. In this case, she very clearly has fatty liver. How does that change your treatment plan? Again, you want to get more aggressive with the antioxidants, more aggressive with the liver support. You know, those antioxidants, again, grapeseed extract is one of my favorite at lowering cholesterol. It's very easily absorbed. Alpha lipoic acid. You know, if anyone wants to know what products I use in my practice that has these things, then you feel free to email me. You can go to my website and just email me. So CRP being at 6.51, this is another marker that is very, very misunderstood, okay? CRP, really there's no safe level of CRP. It should be undetectable. It should be 0.5 or less. If you have any amount of CRP, even a 1.2 or 1.8, that's still a sign of systemic inflammation. CRP is actually not specific to the heart, as we know. Most of it's made in the liver, but it can be a sign of both heart, liver, and gastrointestinal inflammation. It's a specific interleukin, interleukin 6, interleukin 10. Those tend to increase CRP the most. And so, yes, this is active heart and liver damage, and it makes sense with her cholesterol, atherosclerosis, diabetes. This patient's needing some support quite quickly. Homocysteine, and she's also, by the way, suffering from long COVID. So I've been, as some of you who've heard me lecture know, I was studying SARS-CoV for 10 years before COVID came, and so I've developed protocols all throughout that have been used in thousands of practices. So she's suffering from long COVID. Of course, CRP. I have many studies that show CRP is one of the greatest predictive markers, even better than vitamin D, dare I say it. But it's, in terms of a predictive marker, CRP is much more predictive for the severity, comorbidities, and mortality, morbidity and mortality of COVID. So if someone's has CRP going into this, that's the true underlying pathological, predisposition for increased COVID mortality and morbidity. It's that inflammation. And almost everyone who has long COVID has had leaky gut going into COVID. So that's another clinical pearl. Homocysteine at 10.6. LabCorp continues to be more and more, non-scientific in their ranges. Again, we're not using LabCorp because they have, robust interpretive skills. That's our job. They are an excellent lab, though, in terms of accuracy and of course, availability and access. But 0 to 19.2, again, 0, you're dead. 19.2, you better have a good will, and because your time on this earth is pretty limited, at least in any real functional way. So studies show that at 19.2 or anything above a 15, your risk for a cardiovascular event is 80% in 2 years. So within 2 years, the likelihood of having a cardiovascular event. The reason why it keeps getting bigger is because there's more and more people with elevated homocysteine. So at 10.6, it's not horrible, but it's not healthy. And what I will tell you about homocysteine is a rule-in marker. It is not a rule-out marker. Just because she has even if she had a 7, that does not mean she is methylating. What is the main methyl donor? Another Jeopardy moment, the main methyl donor is SAMe, right? Homocysteine often correlates with SAMe levels, but not always. There are situations where if they have a low protein diet, which we suspect that she did, or she wasn't able to absorb her proteins. She wasn't eating, animal proteins with methionine. That methionine is the precursor to SAMe, which is S-adenosyl methionine. And so a vegetarian could have low or normal homocysteine, but be very deficient in methyl groups because of the B12, because of the folate deficiencies. And so what I run is a SAMe test. So there's other lab companies that can run more of a methylation profile. To me, running genetics might be interesting, but we have to deal with the phenotype first. What is she expressing? If she's not making enough SAMe, then she needs, folate and B12. I may run at this point a B12 and folate. I'll get to some of my common add-ons here in a minute. So can you start to see just the amount of information that we can glean from a patient just from a simple blood chemistry test that costs less than $300? It's really it's not my only tool by any means, but it certainly is one of my greatest tools here. So now let's get into the thyroid markers that this panel contains. Now another really important marker, and again, I try to, with blood chemistry, I'm a lab geek, and I look at studies and I read studies. I read big, thick blood chemistry, textbooks. So we really have to be careful. And the one thing that I don't like about functional medicine is we tend to get into, sort of this guru model where, well, some functional medicine guru said it one day and it just kind of stuck. A TSH below or above 2.5 is absolutely not always a bad thing, especially as you get older. And in this case, this patient needs more TSH in order to get her thyroid going because she is in a low thyroid state. So in younger people, yes, I want the TSH, between a 1 and a 2. That's ideal. But this is why we look at the actual T4. We look at the T4, the T3, the free T3, and sure enough, we can see that her T3 is low. But her T4 is okay, right? Her T4 looks good. So we can see, and in some laboratory laboratory interpretation software, it will give you the T4 to T3 ratio. Her T4 to T3 ratio is very high, but you can just do it in your head, obviously. And that is a selenium deficiency. It's a vitamin D deficiency potentially, because it's a vitamin D dependent enzyme, the 5' deiodinase. But she's okay in the vitamin D. She may need more, vitamin D receptor SNPs. I don't want to get too into that debate, but vitamin D receptor SNPs, if you're homozygous, then yeah, maybe you do need a little bit more, but not 80 or 100. Really, what vitamin D receptor SNPs tell you is that their chance of having a disease from low vitamin D is greater, not that they need more vitamin D. So I'll repeat, vitamin D receptor SNPs, and looking at the research, it does not tell you that they need more vitamin D in order for vitamin D to function. What it tells you is that low vitamin D is more devastating for them. Okay, so just really clear. And again, they may need a little bit more, but not what a lot of practitioners are doing. And so so I try to bust functional medicine fads, you know, because this is the only way that we are going to bring functional medicine into legitimacy and into real clinical care where it needs to be. You know, I have a vision that it'll be in the hospitals and it'll be available at you know, primary care physician offices around the country. So it may take a while to get there, but this is how we do it. Is we do it through clinical and you know, and science-based evidence. So that you know, seeing both sides of the argument makes sense. So vitamin D is kind of like that. So you get people out there who are like, oh, vitamin D makes no difference, which is ridiculous. But they're also looking at some data that shows high vitamin D isn't necessarily as helpful as you know, mid-range vitamin D. So I'll get off my vitamin D soapbox, but we don't want to practice fad medicine. Okay. So her clearly she's selenium dependent, and this goes back to the trace minerals. So now we've got this evidence, clear evidence. Also, the thing about these tests is, in terms of a medical legal standpoint, you now have a legal basis to give her these nutrients. So this covers you, you know, for whatever reason. I mean, it's just good to have in case a family member or they come back and say they didn't need all those things, which if you're doing your job, that shouldn't happen. So the other thing I want to point out is reverse T3. Okay, reverse T3 at 20.9. That's very high. That is one of the most accurate inflammatory markers. Okay, when we look at the literature of reverse T3, it is associated with almost every inflammatory disease that we know of. And the higher it is, the worse the inflammation, the worse the autoimmune, the worse the mineral deficiencies. So reverse T3 is a very, very, very good surrogate marker for you know, inflammation and potentially autoimmune processes. She doesn't have thyroid peroxidase antibodies and thyroid globulin antibodies, but those are so common and they're very predictive that I run them on everyone, because so many people do, you know, when they first become a patient, because I want to see, are they at risk for developing it? Thyroid peroxidase, TPO antibodies, thyroid globulin antibodies can be high for decades before they actually develop hypothyroid symptoms. The other thing that I'll tell you is thyroid globulin antibody almost always shows up first in a thyroid pathology before TPO. It's the easiest to reverse. Once TPO is elevated, then it takes a little bit longer to reverse. Sex hormone binding globulin. I get a lot of questions about sex hormone binding globulin. And again, I just want to remind you that, you know, this webinar is about how to use this panel. It's not how I treat all of my patients. So I'm giving you some clinical pearls, but if you want to know how I treat more in depth, those are in my courses, the nutritional pathology course. But sex hormone binding glob, so how do I treat thyroid and things like that? I know I've given you just a few things, but it's much more in depth. But making the right diagnosis and understanding the true causes is absolutely key in then applying the right treatment. So sex hormone binding globulin is a good marker for a couple of things. If it's very high, that's usually an estrogen, you know, elevated estrogens, elevated stress hormones as well. Sex hormone binding globulin, if it's low, can be a marker of too much insulin, too much testosterone. And her, you know, it's kind of low because she's in menopause. She's an older lady, so she doesn't have a lot of that. But I put sex hormone binding globulin in there because it can give you some good information about hormones and whether then you want to do saliva testing. I usually do most of my hormones in saliva testing for many different reasons, but it's very accurate. You can do it in blood too, but blood hormones only show you what is being produced in the moment, what is being produced in the last 12 hours. Saliva is more accurate in terms of what's being stored in the tissues, what's being released in the tissues, what a patient is actually being exposed to. It's even more important to run saliva if they are on any kind of hormone replacement or progesterone or estrogen or anything like that. So I think blood testosterone is fine. Unless they're on testosterone, then blood testosterone is not going to be accurate. You have to run the saliva test if you are taking any endogenous hormones. She is ANA positive, and she has a homogeneous pattern, and that's the ICAP nomenclature, AC1. Sometimes doctors, it gets reported as just that too, but homogeneous is almost always lupus. So she's developing lupus. ANA at 1 in 320 is relatively high. If it's 1 in 80 or 1 in 160 titer levels, then oftentimes that's just systemic inflammation. That's a high cell turnover. So why would the body be making antibodies if it wasn't an autoimmune? Because when cells turn over at a faster rate, that releases nuclear material, the body will develop temporarily antibodies to help clean up that nuclear material. So it's a good inflammatory marker. Don't jump to the conclusion that they have lupus. I will not even run what you could do at this point, a 1 in 320. You could run an isoenzymes, right? You can do an ANA subenzyme to see if for Smith, RNP, SS antibodies are elevated. Why at this point, you can, but maybe 1 in 320 would show that. But if it's 1 in 160 or 1 in 180, or 1 in 80, it's probably not going to show the enzymes. There's just not enough of it to show. So, but in this case, we already have enough information. It's not really going to change what we do, with treatment. And so, that's a cardinal rule in ordering anything. If it's not going to change your treatment, then you shouldn't really order it unless you are just satisfying some curiosity. But then be clear about that. Her white blood cells are high because she's in systemic inflammation, and we know that it's not an infection because her lymphocytes are elevated. If it was an infection, it would be neutrophils. And by the way, usually in viral infections, you don't get an elevated white blood cell. You usually get elevated white blood cells in autoimmune and in bacterial infections. So just a little clinical pearl there. So, we can see MCV being, sometimes that's a good surrogate marker for methylation. So, but again, if you're iron deficient and B12 folate deficient, you can be right in the middle, and still have a problem with that. Because they're homocysteine to 10.6, I'm going to go ahead and run a SAMe test for this patient just to see if she does need some methylation support. Likely she does. I just ordered it because this was just a couple weeks ago. So we'll see. The other really important marker that I added to this panel is the ESR at 30, and sedimentation rate is a really good marker, again, for inflammation. It is not the only marker. Just like homocysteine is not the only marker for methylation, ESR, or your sedimentation rate, is not the only marker for inflammation. But if it is above a 12, it's kind of like CRP. There's really no healthy level for sed rate. The more proteins, the more inflammatory issues, the thicker the blood, the quicker, the higher that number is going to be. And so, 4 is kind of normal, but if it starts to get above that, 10, 12, 20, then, and here she's at 37, again, another marker that she's severely inflamed and undergoing an active, likely autoimmune process. This is the urinalysis. This is a urinalysis with microscopic. A urinalysis with microscopic is really important because in LabCorp's world, a microscopic will not be triggered or indicated unless there's, white blood cell esterase, unless there's, something that's positive in the test strip. So this top part is just the test strip. What I will tell you, though, is it's a very, very sensitive marker for ketones. So if your patient truly is in ketosis and you want your patient in ketosis, then that bilirubin, that ketone is really, really important. And I go more into urinalysis in my lab book as well. So there's a lot you can glean, but that's a really important one that people often miss. Or they think, if you have ketones in your urine, you're diabetic. And no, actually, we want healthy people sometimes. You don't have to have ketones in your urine to be healthy. Make no mistake by that. But if a patient's losing weight and they're really following your plan, then often the ketones will show up. That's not a bad thing. It's actually a good thing. But I do a microscopic because a fair number of women, a few men, have chronic dysbiosis in the urinary tract as well. It's not bad enough to create an infection, but I want to see, are there white blood cells? Are there casts? Because that can tell you if they're forming kidney stones. Is there bacteria seen? So just in your instructions to your patient, let them know that the bacteria, they need a clean catch. And usually every bathroom in LabCorp tells you how to do the clean catch, but just mention it to the patient that you want a clean catch. So that needs to be treated. If they've got dysbiosis in the urinary tract, then they've got dysbiosis in the gut most likely, because that's where it comes from, right? 80% is E. coli, another 10% is Pseudomonas, another 5% is Klebsiella. All of those are gut bacteria. Okay, so common add-ons, vitamin B12 and folate. That's the code. So I'll often do that. Epstein-Barr. I'll do a full diagnostic panel. Lyme disease. If they have low lymphocytes, low white blood cells, that's a sign that they might have a chronic viral infection. So I'll do viral testing. I'll do immune testing on a lot of my patients. If they want their ABO type, then that's the code. I'll do TMAO as well. TMAO is a good marker, especially if somebody is taking carnitine, right? If you put them on acetyl L-carnitine, you want to track TMAO, because TMAO can then be a marker for damage to the heart. If somebody is taking carnitine and they have dysbiosis and leaky gut, then that can raise TMAO. So I'm going to just watch TMAO because that is a really good predictive marker for heart disease and heart damage. So, and like I said, hormones are, I usually do them with saliva testing. So, that's, I was going to go through a case study, but that's the case study. I had another case study if we had time, but we don't. I am going to, just remind everyone that, what we covered. Autoimmune and inflammation, how can you know if it is or will be active? Well, you look at things like reverse T3 and CRP. You look at the titer levels of the autoimmune, ANA or rheumatoid factor. These can be elevated for decades before, an active disease or symptoms show up. So it's important to treat it before symptoms show up. The most important aspect about CBC is, again, one, dehydration from the hematocrit, and also the MCV being a very good methylation marker. Infections, are they active or contributing to disease? If you have elevated or lowered white blood cells, if you've got the lymphocytes, neutrophils, monocytes, hers monocytes were really elevated. That's a sign of active autoimmune. What homocysteine is really saying about methylation, you have to look at SAMe. It's a rule in, rule out test, not a rule out test. We talked about ketosis in urinalysis, hidden UTIs, mitochondrial function such as creatine kinase, LDH, carbon dioxide. Fasting glucose and hemoglobin A1C, yes, it can give you an accurate picture, but be careful if you are taking antioxidants. It will increase the hemoglobin A1C. Hydration and adrenal function, again, that's sodium serum, serum sodium. It is albumin and hematocrit. The CMP, about the microbiome, gut, and diet, that's BUN and creatinine, BUN being low protein intake or low good bacteria. High may actually be dysbiosis and SIBO. And so I gave you some of my treatment pearls throughout. I've got many more, obviously, in my classes. It is a whole certification course. It's 6 modules, and you'll be certified in functional medicine and nutritional pathology at the end. So please visit my website, drbrandonlundell.com, for more information. You can go to my courses page. Feel free to email us. We'll get back to you with any questions you have. And I really, really appreciate Dr. Beakey and the whole team at Professional Co-op. I think everyone listening here who's experienced, who's using Professional Co-op knows that they are the top-notch team. Dr. Beakey has put together very intentionally one of the best customer service teams I've experienced in any industry. So thank you for having me today, and thank you for putting all this together.
Well, thank you so much for the compliment, Dr. Lundell. Very much appreciated, and we totally appreciate you and all you bring to us with the superb knowledge base that you have. And walking through this panel in such detail is a tremendous help to a lot of people. So you really did something good today, and thank you so much for that. As you always do.
I can stay for a couple minutes if there's any questions, but
we do have a couple questions, so I'll quickly go through if you want.
Sure. Yeah.
Sure. So somebody mentions, low CO2 that you mentioned. Do you think that could possibly be due to somebody maybe hyperventilating while they were getting their blood drawn?
Yeah, that can happen for sure. That you'll often see other markers of that though. Elevated glucose when they're not diabetic. Sodium serum might be a little bit high because it's retaining sodium. You'll see some other markers of that, but yes, that's possible. I haven't seen that, but that's possible.
And I will mention quickly that the video and slides will be available on our website for our members. After you log in, go to the video library and the Master Series, and you'll find all of these things, and you'll see some of Dr. Lundell's work there as well that he's already done. Let's see, lots of people saying thank you, Dr. Lundell. Oh, great. What does a high globulin indicate?
High globulin indicates an infection. It could indicate lymphoma or potentially leukemia, but usually it indicates it could be severe dehydration. It can indicate some kind of gamma globinemia, which again can be an autoimmune disease or a kidney issue where the kidneys are not filtering out some of those gamma globulins. I just had a patient who has gamma globulin or IgA nephropathy. So sometimes you'll see high globulins in that case. As the nephrosis continues, though, then you'll see low globulins because the kidneys are dumping, the globulins when they shouldn't be. So, but look to some kind of autoimmune or bone marrow, some sort of white blood cell disease in that case.
Okay, how about the cause of inflammation? Do you see that mostly as food or drinks or lifestyle?
Yeah, I mean, take my courses. That's what we go into. I mean, it is many things. I mean, it's pollution that we're exposed to. It's stress. But what I can tell you is the greatest source of inflammation is obviously leaky gut, because 80% of our immune system, by count, if we counted up our white blood cells right now, 70 to 80% are in the gut-associated lymphoid tissue. And if there is leaky gut, dysbiosis, those kinds of things, then that is triggering the interleukin, the cytokines. That's where most of the cytokines are coming. But then, also oxidative redox balance, low glutathione, low SAMe, that's a huge cause. So nutritional deficiencies, the body not being able to make enough antioxidants, or the body not being able to consume, or the person not being able to consume through bad diet, or also the hallmark of leaky gut is not being able to absorb micronutrients as well. So, so that, yeah, the cause of again, stress and pollution, leaky gut, those are kind of the top ones. Infections, obviously, those are the top ones.
And we also have 35% of the adult population in America with metabolic syndrome, which would be a nice linchpin for inflammation in and of itself.
Exactly. Yep.
Oh, let's see. Well, here's interesting, a take on a case from somebody, 21-year-old female, CK519, LDH 248, ALT 34, A1C 7.2, CRP 12. Any thoughts on that?
Oh yeah, I mean, she's obviously got diabetes and fatty liver, and metabolic syndrome to the max. Maybe, how old is she?
21.
Yeah, so maybe even PCOS would be something that I would look into. Look at DHEA levels. DHEA levels are a good correlate marker with PCOS. So if DHEA is high, or insulin, testosterone, those can be associated with that. Those people tend to have low vitamin D. Vitamin D really helps those patients, as well as, again, the trace minerals. Dealing with the leaky gut, giving them a lot of anti-inflammatories, right? The curcumin, the green tea extract, the grapeseed extract, the alpha-lipoic acid, the CoQ10. If you want more about the nutrition of how to treat all these things, you can take my classes. I do consults as well. So if patients, or if your doctors out there are stumped on any patients, give me a call. We can take a look at the blood chemistry, and I can give you kind of an individualized look at what we can see going on with the patient. So again, you can.
We'll go on record here as officially recommending your course. So
yeah,
that would be pretty good.
I appreciate it.
And let's also mention that you're going to be at a conference in Phoenix next month for NutriWest. You're doing that, so I will be there. I'm anxious to hear more of what you're saying, and some of the other speakers will be great as well. Yep.
Yeah. If anyone wants to come out, you can go to NutriWest website and sign up for the symposium out there. I love teaching at that symposium every year. Some good speakers, and we really take a deep dive into nutrition and things that I use in my practice. So makes it more practical for everybody.
Okay, I have two more quick questions here. What about fungal infections, increasing the lymphocytes in diff?
Yep. It has to be a pretty active fungal infection. It's why I actually test for some of the fungal infections. You can test for mycoplasma, you can test for, candida, you can test for some of those. What I will tell you is that mold and those kinds of things don't usually increase the lymphocytes unless it's a really acute exposure. You're only going to get lymphocyte and potentially monocyte activation in the first maybe a couple months, 3 to 6 months max, and then you're going to start seeing a sharp decline, typically, depending on the person, but typically that's what happens. So I will tell you too that I may ruffle some feathers with this, but I believe wholeheartedly that mold is being overdiagnosed. It's sort of again, functional medicine has a bad habit of taking something that's real and true and over applying it to everybody. I don't believe that everybody has a mold issue. Everyone has MCAS. Everybody has SIRS. Those are sort of, those exist. Don't get me wrong, but you have to really dig deep and really make the accurate diagnosis. Don't just assume. And a lot of urinary, mycotoxin tests, mold toxin tests really aren't. They're just not. They're not up to prime time yet. They're not reliable markers yet. I think they serve a value, but things like aflatoxin, I mean, that's in food. You're just basically measuring what's in food and transient in the body. that can be helpful in changing their diet and not eating things that are moldy. But people are over treating it, and it really gives functional medicine kind of a bad name. So just do more diagnosis and more investigating. It's like Lyme disease. It can be really hard to find, but going the extra mile or two in diagnosis can really help you. Yeah.
And the one last question we'll have time for, do you have any markers that you believe reflect B1 status?
Yeah, that's a good question. Because thiamine is so intimately connected to blood sugar metabolism, I would say elevated, blood sugar, elevated hemoglobin A1C, that might be a really good, early indicator of that as well. But again, it's also necessary for the mitochondria. So, running, looking at the mitochondrial tests. If you want to know more about mitochondrial tests, then I would run an organic acids test, okay? And there's several companies out there that do it, but you can run, the succinic and malate. You can run some of those tests to really look for mitochondrial dysfunction. And one of my favorite tests, you can do an actual micronutrient test. I won't mention the name of the test because that's not, the purview of this, but it's a micronutrient test that tests for all of the B vitamins, not levels in the blood, but actually how your cells respond to them. So I can give, again, if you email me, I can give you the name of that test.
That question was written B1 and then riboflavin below it. So.
Oh, funny. Yeah, B2 is riboflavin. That's okay. It happens.
No, little tight.
Yep. Yeah. Riboflavin too, though. Riboflavin is really important. People don't realize how important riboflavin is for methylation. So everyone's B6 and B12 and folate, but riboflavin and niacin also extremely important for that. So yeah.
Well, thank you so much, Dr. Lundell. Brilliant presentation, much appreciated by one and all. And thank all the folks for coming and listening as well. We appreciate your time. And
thank you very much. Yes.
Bye-bye, everyone.
And namaste to everybody.
We'll see you next time. Have a wonderful day.
Okay. Bye.